My name is Orla. I'm a heart specialist, and I'm going to keep it relatively brief in terms of talking to you this evening about the kind of things we're doing in terms of trying to improve our understanding of children who have both Down syndrome and congenital heart disease. Because as you know, 50% of kids born with Down syndrome will have something wrong with their heart that is severe, life-changing, life-threatening, and that needs to be fixed. And if you look at the numbers, it depends on what papers you're reading. Between we have a concentration of expertise of Down syndrome in Ireland by virtue of the fact that we have a large number of children with Down syndrome. And so therefore we have large groups of doctors looking after them. And depending on what papers you're reading, between 1 in 440 and 1 in 540 kids that are born in Ireland will have Down syndrome. This compares to about 1 in 800 in Europe. And so therefore, we have an opportunity to cohort kids together and to generate data that we have an obligation to share then with everybody else, such that we can improve the lot of all. I know you know an awful lot about Down syndrome, and it is essentially about 160 years since it was first described by John Down. And he described the physical features, and it took another 80 to 90 years before we understood the concept of trisomy of the 21st chromosome, 3 copies of chromosome 21. And from my perspective, then things really started getting interesting in the 70s, where for the first time, advances in terms of cardiothoracic surgery and particularly advances in terms of bypass began to generate interest in the concept of operating on children. Because of course, before 1970, everybody with complex congenital heart disease died. Everybody's mum knows a child who lived in their neighborhood who was weak, sickly, had recurrent hospital admissions and died at about 6 or 8 years of age. They were the kids with congenital heart disease. And in 1970s, the landscape for those children changed, except of course if you had Down syndrome, because not everybody was interested in operating on you if you had Down syndrome. And there was an absolute policy of excluding children in the 70s who had complex congenital heart disease from cardiothoracic surgery. And when I went to London in 1998, that was still happening. And some of the older cardiothoracic surgeons did not operate on kids with Downs, and it was accepted by all as a version of normal. Okay, absolutely nothing that we'd accept now. And then in the late 70s, you know, it was 1998 was still happening, but in the late 70s, some brave people began to put up their hand and say, well, actually, you know what, this isn't good enough. And it isn't good enough because the problem probably isn't the Down syndrome. The problem isn't the hearts. The problem is our attitude to that. And the fact that we as doctors and nurses are not giving these kids enough attention and trying to look into the granular detail of why they can be a challenging group of kids to look after and to get over the line in terms of cardiothoracic surgery. And having originally started 160 years earlier with Downs actually diagnosing the condition, we got into the 70s where a lead pediatrician in the States called Feingold said, children with Down syndrome have a high mortality because they do not receive adequate medical and surgical care and not because they have Down syndrome. And that is true. And it is our unraveling of that statement that is the basis of much of what we are doing in relation to hearts. The panel on the right is lots of interesting kids with Down syndrome whose pictures I have shamelessly stolen from the Down Syndrome Ireland website. You probably know loads of them, and I'm privileged to have some of them attend me. Their individual narratives and stories are excellent, interesting, and from a medical practice point of view, relatively worthless until you cohort them together and start talking about them as a group and generating data. And it is only through research and data generation that medical practitioners actually start listening. So let's just put some figures to these gorgeous kids on the right and I suppose focus on issues very specifically and unashamedly in relation to the heart and give you some numbers. And the numbers aren't great. 50% of kids with Down syndrome will have heart disease, and that compares to less than 1% in the general population. So you're 40 to 50 times more likely as a child to have heart disease if you have Downs than if you don't. In the case of your heart disease, 60 to 70% of those diagnoses will be made prenatally. We're getting very, very good at that. And that gives a parent an opportunity to absorb and to understand the journey that they're going to have to take with that child and to develop key relationships in advance of the child being born. 10% of all children undergoing cardiothoracic surgery worldwide have Down syndrome, unless you're in Ireland where the number is 22%. So we are operating on huge numbers of children, and we are now beginning to tabulate and document what we do for the benefit of all. Very shockingly, 7.5% of children who have Downs will die in the first month of life. I didn't know that until about 10, 15 years ago, when people began to produce this data. And so we set out in the Rotunda to prove that it was completely wrong. And we were wrong. Because of 121 consecutive infants with Down syndrome, we found that 45% of them were admitted to the postnatal ward. So 55% had Downs and needed to go to the neonatal intensive care. 45% went to the postnatal ward. But unfortunately, 70% of that 45% actually ended up eventually on the neonatal intensive care, where 2/3 of them had congenital heart disease and 1/3 of them had pulmonary hypertension. And pulmonary hypertension is the killer of newborns typically with Downs. And 6% of those kids in the Rotunda died. That seems shocking. And if we presented that statistic in relation to children with a typical chromosome complement, people would be up in arms. 2.3% of infants with Down syndrome need extracorporeal life support because their pulmonary hypertension is so bad. And it was Martin White, who works in the Coombe, who took the brave step about 6 years ago to send a child to Karolinska to receive extracorporeal life support when they had pulmonary hypertension, even though they had Down syndrome. He broke the mold. And since then, 1 to 2 children a year will go and get the benefit of treatment that is life-saving and without which they certainly would not have a future. So what's the impact? In Northern Europe, they're not so good, I think, in terms of numbers, in terms of Down syndrome, but they're absolutely excellent at creating and collecting data. And if we look at the Swedish Health Registry, they looked at 47 years worth of data in children who had congenital heart disease, and they looked at 90,000 kids with congenital heart disease overall. About 64,000 of those had congenital heart disease with a normal chromosome complement, but they had 3,000 kids, over 3,000 kids who had heart disease and Down syndrome, and they matched those then with 26,000 controls who had neither heart disease nor Down syndrome. And they found that over that period, if you had Downs and heart disease, you were twice as likely to die if you had Down syndrome and heart disease. And you were 25 times more likely to die if you had Down syndrome and heart disease than if you had a typical chromosome complement. So there was a problem that we need to help them address. The way we do it in Ireland is we operate on absolutely everybody who has Downs with AVSD, which is the most common cardiac lesion that we see. And we are completely transparent in terms of our data. All of our data is sent to a thing called NICOR. We're in the British Isles. Every one of the 10 cardiothoracic surgical centres contribute. And you can see there, we're number 23 on the plot. And that means we operate on more kids with AVSD and Down syndrome than anywhere else in the British Isles. So if you want to get really good surgery, come to Dublin, because surgeons who do things a lot get very good at it. We have a mortality, though, if you look at that is higher than some of the UK centres who operate on very low volumes. And that is because we're pretty equitable in terms of offering children surgery who might necessarily not get it in other places. And there are 4 major kids groups who die as a consequence of AVSD, for example. So children who are Downs with preterm terrify us because they have pulmonary hypertension that can be lethal. Children with Downs who are small are at significantly increased risk. And then the other 2 groups are the children who have left heart obstruction. So we have a high mortality. If you have an AVSD, which is the most common lesion we see in Down syndrome with heart disease, and you have a blockage of your aorta, that's a really bad combination. And then the worst combination of all for an AVSD is if you have normal chromosomes. Our mortality in the children who do not have Downs is much higher than our mortality in the kids with Downs, because the kids who have a typical chromosome complement tend to have awful AVSDs, unlike the kids with Downs who have a lovely balanced version of the lesion for which the surgeon can offer a lot. And this is the culprit. This is atrioventricular septal defect, which is the most common cardiac lesion seen in children with Down syndrome. And you have the large hole on the top, sorry, I don't have a pointer, and there's a VSD hole in the bottom and a common valve. And we spend a lot of time sorting this out. As I said, 22% of all our patient population. And the reason, though, that children are harder to get through, the reason it can be a big journey for the patient and their parents is not actually the heart, because children with Downs and heart disease tend to have relatively simple heart disease. They tend to have lovely balanced ventricles. They tend to have holes that are easy to deal with. It's all the other stuff. And people have talked about multidisciplinary needs, and it's the other stuff. The fact that they're small, they have an increased risk of prematurity. And the big, big problem is pulmonary hypertension, high lung blood pressure. This is the big killer of children with Down syndrome. So what is all the fuss about lung pressure? Okay, the pressure in your lungs should be lovely and low. Blood should be literally falling from your right ventricle into your lungs in a very easy and unobstructed way. And the job of the right ventricle is to push blood into the lungs. In kids with Downs, they have a smaller number of alveoli. They have far more muscle in their lungs. Their lungs are made differently. They have an innately high pressure in the lungs. And if you upset them by doing something like cardiothoracic surgery, by giving them pneumonia, that pressure will absolutely increase. And suddenly the workload in your right ventricle gets very, very difficult. And it's an uncomfortable place to be, and children struggle on intensive care. In the lungs, as you know, the oxygen that we breathe that's taken in from the air is added to the lungs, and then that beautiful red oxygenated blood is returned to the left ventricle that has a different job. That pushes blood out into the body. And kids with Downs don't have a huge problem here. The big problem is that they have lungs that let them down when they get sick. And it is understanding that heart-lung interaction that is important and absolutely vital if you're to get children over the line. So pulmonary hypertension is where it's at and where it's all about. So equality of outcome is only possible if you acknowledge that there are differences. Children with Down syndrome have very different heart-lung interactions to children who don't. You have to acknowledge them and you have to mitigate for them. And you can only mitigate for them if you're collecting data. And this group of 3 amazing women with whom I've been working have looked at kids with Down syndrome in the areas of pulmonary hypertension and heart function. And that was Aisling Smith. Ludmila Zhakarenko has looked at the perioperative experience, what makes things harder for kids with Downs, and in particular, why the abnormal inflammatory response that we've heard about from Rob earlier interacts with the heart and lung and makes things particularly challenging. And Michaela Pentony has looked at challenges with feeding. And I'm going to sum up their findings in a very easy way, and I suppose acknowledging the fact that the findings going to present are the collective of about 7 years of work. So Aisling Smith, what did Aisling do? Well, what we knew was that there was very little data. People hadn't been terribly interested in collecting data about the heart in children with Down syndrome and that heart-lung interaction. We knew there was more to be learned. And so we thought we would look at it in great detail over the first 2 years of life. And what we thought was that children with Down syndrome, whether or not they had heart disease, would demonstrate an abnormal capacity of their lungs, both to contract, but also to relax. Your heart is relaxed while it fills for 2/3 of the cardiac cycle. And it really does have to relax to allow blood to come in. If you have heart where the muscle is stiff and it's like a tightly coiled spring, your heart won't fill and then it won't eject the same volume of blood. And that can make things challenging for you. So what do? We took kids with Downs as whether or not they had heart disease, and we measured everything about their hearts serially and repetitively over a 2-year period. And what we found was their hearts were different. That even if you looked at their body surface area, their right and left ventricular lengths were shorter. So the hearts are smaller and their capacity therefore to improve their cardiac output, to improve the ejection of oxygenated blood was somewhat limited. We found and actually tabulated that they had abnormal lung pressures. The right ventricle was having to do tremendous work pushing against a highly resistant set of lungs. And whether or not they had heart disease, that was something that we encountered in the first 2 years of life because their hearts were not as good at contracting and not as good as relaxing. And this was causing problems for them. So what we did was we published the largest prospective studies ever been performed in the world, looking at evaluating longitudinal myocardial function and pulmonary hemodynamics in kids with Downs. And we are the second most published group on Downs hemodynamics worldwide in an environment in Ireland where getting funding for anything like this is very, very challenging. And so what we said was, kids are in trouble because they have a very abnormal heart-lung interaction. And if you put them under stress, you will make that worse. And that explains some of the reasons why kids with Downs who appear to be great suddenly get a pneumonia and they're absolutely floored. They end up in the ICU and they're absolutely struggling. So we looked at those kids, and what we did was we got that and we got people to understand that, and we published. And we published on this topic probably about 10 papers now, and will be considered one of the premier publishing groups. And in a way that doesn't matter. It doesn't matter that we're communicating with other doctors, but what are we doing that actually is different? Well, we've changed the way we see kids with Downs. Every child who has Down syndrome, whether or not they have heart disease, should be seen at 1 and 2 years of age to look at their heart-lung hemodynamics, and should be looked at by a cardiologist who has an interest in this. Every single teenager, whether or not you have a cardiac history and you have Down syndrome, should be seen at about 13, 14, 15, the early teenage years, looking for pulmonary hypertension. And if you look at the literature, you'll now see that 1 in 20 of them has pulmonary hypertension, and this will seriously disadvantage them if you ignore it. So that was our heart-lung interaction. What do we do with Ludmilla? Well, we thought, gosh, the most stressful thing that could possibly ever happen to you is that somebody opens your chest. We open the chest, we don't induce infection, but we induce a thing called inflammation. Where you open the chest, cardiac surgery will trigger an enormous inflammatory response in children, and your body begins to fight the situation. It fights the situation by producing chemicals called cytokines, the kind of inflammatory markers and things that Rob has talked about earlier. And what that does is it, at a time in your life where you have never needed your heart to work so well, it impairs your myocardial performance, and it also pushes up that pressure in your lungs. So the cardiac surgery alone is a big problem and triggers an enormous immunological response. And that can be responsible for problems short-term and longer-term in terms of clinical outcome. So when we looked at kids with Downs and compared them with kids with the exact same hearts who didn't have Downs, we found that, for example, the children with Downs had higher heart rates, lower blood pressures at all points in their operative stay. They had a reduced capacity of their heart to contract, and often by the time they went home, that still hadn't improved. And so what we found was the kids they weren't as good at filling their hearts. They weren't as good at ejecting blood. They tended to run into problems with pulmonary hypertension. And we needed to know that so that we could treat it at the first available opportunity and at the first sign that it was there. We knew that they had small left ventricles from Ashling's work, and we knew they had a reduced capacity to put things right when things were going wrong. And most importantly, we published saying that this adds to their complexity. So if you're going to look at kids with Downs and try to get them through cardiac surgery, you need to acknowledge all these things. You need to put in place the resources that will actually allow them to survive that pediatric intensive care experience, and you need to give them time, acknowledging the fact that they will have maybe a longer list of problems and that they demand attention from people who are interested. We found that every single outcome in relation to cardiac surgery that is a long-term complication, heart block, chylothorax, where you produce a lot of fluid from your lungs, our use of inotropes, drugs used to help the heart pump, and nitric oxide, an inhaled gas used to help the lungs relax, they were all worse in kids with Downs. They spent longer in intensive care. Their total hospital stay was longer, but you know what? They all survived. Like, we got them through, but in order to get them through, you needed to understand the problem and you needed to be interested enough to ask the question. And then Michaela looked at a third thing. So we've talked about the heart-lung interaction and the inflammatory response and its negative impact on the heart. And Michaela talked about feeding. She talked about, well, we know kids with Downs and heart disease are prone to growth failure. We know they don't grow very well. For those of you who've had babies who've come through our program, you're absolutely, I'm sure, bored to tears with our constant discussion about weight and the importance of weight gain. And the reason that weight is important is that if your weight is poor, you're more likely to die. Children with heart disease are more prone to growth failure. There are multiple factors. You're much less able to feed because you're breathless. Your gut is edematous. You're less likely to absorb the feed that you take in. So you have a real problem, and then you're breathless, and so therefore you're using more calories. So you have loads of reasons why you wouldn't grow so well. And that's super important, because if you're to look at kids with the simplest of the lesions that we operate on, a VSD, a ventricular septal defect, the single most important factor in terms of survival is not your weight, it's not your age, it's your weight. Getting you above 4.5 kilos is key to optimizing your survival. And so therefore, the reason we're obsessed and obsessional about weight is because we want to get above that 4.5 kilos, and we want to bring down the mortality associated with surgery. And there's some beautiful studies in relation to that, the biggest of which is a Japanese study looking at 5,000 consecutive children who had a ventricular septal defect and showing that the sweet spot for weight is 4.5 kilos. So if we know that life is hard because you've got Downs, and if we know that you're more likely to survive your surgery, and 50% of those kids will have a cardiac disease, then the bottom line is we need to really, really focus on getting those kids in shape. We need to get them in training for their surgery, and the way we do that is by trying to get their weight up. So Michaela looked at feeding, and these are the numbers. And, you know, if you have Down syndrome or you have heart disease and you're going to have an operation, 62% of kids will have a nasogastric tube in by the time they go to surgery. And this is necessary. And most people accept that. The problem, though, is what we didn't have for parents was the information. Okay, if we put a tube down on you because you need that tube to grow, how long is it going to stay? The answer to that is 8.7 months. So that's a total pain for families. But at least now we can honestly engage with them and we can say, we're going to put a tube down. And I'm really sorry, once we put this tube down, it's likely to be a friend of yours for the next 9 months of your life. But doing it is going to increase the probability that your child will survive. And the other thing we need to do is to say, well, actually, for most of the time the tube is down, you'll be post-operative. And then the most important interaction is not your cardiologist and your cardiothoracic surgeon, but it's your dietitian. So unless we have multidisciplinary teams resourced to support things like feeding, no matter how amazing your surgeon is, your kids won't do as well. So we found that children with Down syndrome needed more nutritional support, and they need special needs nutritional support from dietitians who are interested and who are engaged with the problems of, more breathlessness, more hypotonia. And we needed them to be present after the surgery and not just leading up to the surgery. And this data has been really helpful in terms of helping us counsel parents and give them realistic expectations of what it is they're going to have once that tube goes down. So the message is that tailored care is necessary for children with Down syndrome. They have a lovely version of an AVSD. Surgeons love operating on them. They are going to get great results, but they're going to take longer going through the ICU. It's not more difficult, it's simply a different approach. And if you don't care enough to gather data on the large numbers of kids that we have here, then you're not going to get the results. It's not simply a matter of attracting the best surgeon. And so in just discussing the topic, what are the recent contributions of Irish researchers, I probably shouldn't have called it that. I should have called it, to achieve equity of outcome in cardiac surgery for children with Down syndrome, you need to understand and to revel in the differences. And most importantly, it is not just the heart, it is largely about the heart-lung interaction. I'd like to thank everybody who's involved in our hemodynamics research program. There are so many pictures up there. It's lovely to see the HRB here. We take money from anyone who will give it to us because it is really, really difficult to get. I am delighted that our team spans Trinity, RCSI, indebted to the effect or to the help of the Feet Velka Fash, and all of our researchers, all of whom are now MD, PhDs, are up there. These are smart people who are now employed, every single one of them in Ireland, and they are looking after your children. I would like to sincerely thank Beth for asking me to speak, for Dave Ryan for looking at my slides. And also, I would like to thank everyone who said yes, because by and large, when we ask people to take part in projects such as ours, they do say yes, and we are grateful. Thank you very much.